Bore da, good morning. Welcome everybody to this Digital Health and Care Wales Extraordinary Programmes Delivery Committee meeting. I'd first like to welcome Olivia Shorrocks, who's joining us as an observer. Olivia is Head of Performance, Escalation and Intervention at Welsh Government, and she's joining us as an observer for this meeting. So you're more than welcome, Olivia. Members will be aware that our escalation status for major programs went from level 1 to level 3 on the 11th of March, and as a result the SSA board has asked this committee to provide oversight on the escalation improvement plan, and as such we've increased the frequency of these meetings, so they're now every 6 weeks rather than every quarter, and we've allowed more time at our usual quarterly meeting for oversight of the plan, and we've introduced this extraordinary meeting every other 6 weeks to dedicate an hour or so to the plan itself, and that's the main item on today's agenda. This is our fourth of these meetings since escalation was approved, or the revised arrangements for escalation were approved, I should say. And I'd like to make a couple of notes before we get started properly, which is not everyone will be looking at the camera. We have some papers and occasionally we'll be referring to those which may be on a different screen, or in my case I've printed them out. And I'll ask colleagues to introduce themselves rather than go around the virtual table at the start when they first speak. And with that said, I'll now move on to the agenda. First up is apologies for absence, and we have two. One from Simon Jones, who's unable to join us, and from Sam Lloyd, Executive Director of Operations. In terms of declarations of interest, I've received nothing in advance of the meeting, so I could just pause and ask colleagues if anybody's got anything they need to draw to my attention before we start. A few shakes of the head, nobody making any points, so we'll move on. First point on the main agenda is the minutes of the last meeting. This is both the public and the abridged private minutes. They're here for us to approve. So can I just check to see if anybody's got any amendments, corrections or additions they want to make before we formally approve the minutes? Great. Okay, so we'll approve the minutes. If you would make a note of that, please, Belinda. Next item is an action log, but there are no outstanding actions, so we can move on to the main part of this meeting, which is the escalation status and the update to the improvement plan from our board secretary and director of corporate affairs, Chris Darling, who's going to provide us an update on the plan. The milestones are due this month, and a bit of feedback from the IQPD session that took place in August. So I'll hand over to you if I may, Chris.
Thank you, David. Yes, Chris Darling, Board Secretary, and the SRO for escalation. So I'm just going to share some slides which reflect the update paper that's in the packs. I'll use it just to talk through the points today that we need to cover. And as you say, David, the main focus will be on two things. One, an update on the September milestones and where we're at in terms of delivery confidence. And secondly, there's two milestones that we just want to get into a bit of detail in. So Ivan and Michelle will cover those. So so that's what we're going to cover. I think everyone on the committee are now familiar with where we've got to in terms of the context to escalation. Just to note, obviously this committee is the subcommittee of the board that's been assigned the role of providing oversight and assurance for the escalation plan. Brief update since the last Programmes Delivery Committee, which met in early August. Since then, we've had one IQPD, so Integrated Quality Performance and Delivery meeting with Welsh Government. As committee members will know, that's the mechanism where we run through escalation status with Welsh Government to ensure it's not adding an additional meeting, because we have the IQPD meetings anyway. At the last meeting, we ran through the delivery status of our July milestones. We had a forward look to some of the September milestones, and we had a deep dive on the two diagnostic programs, LIMS and RISP, and we did a deep dive into the NHS Wales app. So key points I think committee members should be aware of. We mentioned and we agreed that we would have an early engagement session on the digital program typology work and the commercial framework. So that's what Ivan and Michelle will cover later on in today's agenda, and we've got that session with Welsh Government colleagues this afternoon. We looked at LIMS and there was agreement to change the plan to a discipline approach with tranche dates. And we also had the discussion around the congestion in the programmes when you look at both LIMS and RISP and the dates health boards were going live at. I know that's been a risk that we've discussed at committee previously, but that was discussed at the IQPD meeting. And finally, we talked about the NHS Wales app. In particular, we had a request to review the joint working with partners to accelerate the adoption of the NHS Wales app features. So when we come on to the September milestones, I think we'll cover off what that means and what we've done since then. The one other meeting relevant to escalation since the last programmes delivery committee, there's been a DDAT leadership board, and committee members will recall our escalation framework explicitly asks that we use that governance arrangement to help oversee and manage major programmes at a system level. So pleased to say that the leadership board in August did cover the NHS Wales app, Connecting Care, as well as looking at the 2 diagnostic programmes. So if I move on, I'm not going to dwell on the improvement plan, just to say there's 42 milestones within it. In terms of current status, before we move on to the September milestones, so we've had 16 milestones that were planned between April and July. 14 have been delivered in full. There's one milestone, 9.1, which was colposcopy go live, that was due to be delivered by the end of June. That did slip, as committee members know, to the 9th of July. So it has been delivered, but it wasn't quite to time. It was 9 days after the 30th of June milestone date. And one other milestone, which is 4.1, which is around NHS bodies entering into the WASPI joint data controller agreements. And this is to allow data to flow into the CDR as part of the NDR programme. We've had 9 of the NHS bodies in Wales sign those agreements. There's 3 currently outstanding. The current status is that they are due to be complete by the end of September. There's a couple that wanted those agreements to go through their board and committee process, which meant they're going to be drawn out slightly. But at the moment, we're not having any concerns that they won't be agreed. But once again, that is a date that slipped from July to, well, it'll now hopefully be September. So that's the milestones to date. There are 16 milestones. So September, the end of September, is where the majority of our milestones in the plan were due to be complete. So what I've done, I've worked with colleagues just to try and give a current status with evidence and delivery confidence. As you're aware, we're sharing this information in the shared repository with Welsh Government colleagues so they can see where we've got to with delivery. My suggestion, Chair, was that I run through this where the delivery confidence is green. We note the position. Where it's amber, we spend a bit more time because the confidence on delivery by the end of the month is less. So the first 2, Ivan, do you want to comment on the current state architecture and the future state architecture in terms of that milestone, which is due to be presented to the programme board on the 25th of September?
Yeah, certainly. So this is the current and future state target enterprise architecture. There's been a lot of intensive work very quickly done over the last 3 months or so. There's a project board which oversees this work, which I chair, and there's a supplier which is engaged to support all of our health boards. I want to pay credit really to the work that's been done across the architectural community, across NHS Wales. So far we have around about 1,000 different systems mapped into the enterprise architecture map tooling that we are using. We've still got 500 or 600 to go, but we've got enough to do an assessment of the current state. The contractor has completed their first review draft of the current state report, and they're about to submit the first draft of the target state report or the target architecture report. So I've got a reasonably good confidence that we're on track for the end of this month. But a key milestone is the project board, which is on the 25th of September. But we're keeping all the digital directors, all the organisations, and everybody else involved in this. So this work has made, I think, actually remarkable progress over the last 3 months, and that's because of the input from right across the NHS Wales system.
Thanks, Ivan. Item 2.1, the public launch of the NHS Wales app. I'll just cover this quickly just to say the output from this was the public communications campaign, the IQPD discussions that we had in August. I think there was agreement, albeit I haven't seen the minutes to confirm this, but the discussion was that the app was formally launched in May by the Minister at the DDAT, the inaugural DDAT Leadership Board meeting. Therefore, this action should be marked as complete. The public comms campaign hasn't happened, but that is the timing of that is with the Minister in terms of when she feels the most appropriate time would be. So rather than, say it's September, we know it's not going to be September, but we don't really have any control in terms of when that will be. So the go live has happened. So if I move on now to, we've got a couple of amber delivery confidence. So I'm going to start with 2.2, which is the Q1 and Q2 features delivered as part of the silver roadmap for the NHS Wales app. And Ivan, worth just going into a bit of detail with this one in terms of where we've got to, the feedback from IQPD and what we've done in response.
Yeah, so the silver roadmap is, just as context and as background for those who are listening, and why is it silver, is that at the beginning of the year, in January and February, the Minister asked us to set out gold, silver and bronze options for what we would deliver in 25-26 as features in the NHS Wales app. And obviously there's a cost and a resource commitment which varies. So, gold costs more than bronze in simple terms. So we agreed with silver in terms of a delivery roadmap, and we're on track to deliver the features by the timetable that we'd set out in the silver roadmap, very much helped by government confirming the funding for the whole year before the year had started. So that's given us a good solid runway for planning. What we're finding is that many of those features require quite a lot of work by partners to onboard. So outpatient appointments would be a very good example. At the end of Q1, we completed the pilot, or we launched the pilot for outpatient appointments, working closely with Hywel Dda in general surgery. But there are across Wales tens of thousands of individual outpatient clinics. All that information is stored in WPAS, the Welsh PAS systems that are managed by each of the health boards, and there's some validation that is needed to just check the way that outpatient clinics are described, their names and their codes and so on, before they're visible in the app to users, because they'd never been, the wording that is used in health boards was never expected to be visible to patients, and now we're making things visible that were not originally anticipated to be visible. So we just need to go through a validation process. That takes some time because there are tens of thousands of clinics, and so they need to be reviewed individually. So that's what the DDAT Leadership Board is reviewing tomorrow. The DDAT Leadership Board is the most senior digital data and technology leadership board in NHS Wales. Its membership includes all of the chief executives, and they're dedicating a session tomorrow to looking at options to accelerate this onboarding process of how do you get a feature from it being live in the app to being available to all users across the whole of Wales, which requires quite a lot of onboarding. The reason that the delivery confidence is amber is because we're scheduled to make some clinical documents or letters available in the app as a pilot or as an alpha by the end of September. And our assumption had been that we'd follow the same roadmap as we'd followed for appointments. So we'd build the feature, we'd make it available, and then things would be onboarded individually. What we found from outpatients is that outpatient appointments that there's a lot of heavy lifting involved in that. So we're looking at the design of, or we're reviewing the design after completing a discovery exercise. We're reviewing the design of how we're intending to do letters to see whether we can simplify that onboarding process. The consequence of that would be that we may miss the alpha delivery timetable, but we would end up with a lot more confidence of when we get to all Wales and all users, because at the moment it's very, very difficult to predict what the all Wales, all users timetable will be. And that's what ministers are interested in, understandably, and that's what users are interested in. I'm a user of the app and I want to know when I'm going to get it. Whatever that new feature is. So we're looking at that, and that's why it's amber, because we may need to pause or delay the alpha delivery, but we would do that only in order to accelerate the delivery of the whole feature available everywhere for all users across Wales. And we're working through that right now.
Okay, thanks, Stephen. Before you press on, Chris, Rowan's got a hand up. So, Rowan.
Yeah, Ivan, I can see the process flowing very clearly here. How well tested is the DDAT leadership board in being able to opine on the validation of clinics, process, content in clinical letters, and effectively stick a decision across the whole of Wales NHS? Have we tested that? And because it's kind of key to being able to hit this date.
Yeah, it's not for us to test as such, because this is governance that has been established by Welsh Government. I'm optimistic. I'm confident, because the DDAT Leadership Board, over its last 3 meetings, has sort of reviewed or has taken an update on the NHS Wales app and on a couple of other senior or major programs, LIMS and risk diagnostics programs particularly. And we've worked with digital directors to ensure that their chief execs are briefed on the context. So we had a couple of hours last week with digital directors in the run-up to DDAT Leadership Board tomorrow, to make sure that digital directors are able to brief their chief executives. I mean, they are the collective chief executives of the NHS in Wales, so if they make a collective decision, that should stick. It's not for me to test whether that works, but there is no more senior decision-making forum in the NHS in Wales, and so so hopefully we'll be able to come up with a clear position. It's the health boards that have to validate their outpatient clinics, and so chief executives briefed by their digital directors will know better their capacity, how they would prefer to handle that. The program is giving them some resources to support that, for them to use in whatever way they think is best in their own organizations. But we from DHCW can't go out to validate the outpatient clinics or to find the contact details and numbers and emails of each of those clinics on behalf of the health boards. That's something that has to be done by the service delivery organizations.
Yeah, I think that's a really clear delineation of responsibilities. Is there precedence within the NHS in Wales for secondary care information to be provided to residents in Wales directly, and through?
Well, in this case, yes, because patients get letters from outpatient clinics inviting them to appointments. That's how they know they've got an appointment. So although they don't always get letters, sometimes they get a telephone or they've arranged a follow-up there and then, so they already have the detail. What we're validating is the particular detail of the information that appears in the app, and also we're conscious that all that will hit at the same time. So letters go out daily, but all the appointments will land in the app from when you turn on the clinic. All of those appointments will, and that could create a surge in inquiries to health boards. So it's those sorts of things that we picked up and we're reflecting on as a result of the discovery work, and then the pilot that we did in Hywel. That's why we do these pilots, is to not just for the technical but for the service as well.
Thank you, Ivan. That's really helpful.
even before you move on, can I just ask a couple of questions? So in terms of all of the things that we're delivering as part of the silver package, this one seems quite complex in terms of its deployment. There's a lot of work to actually get it to deployed. Is that the exception to the package of things that we're adding, or are there a lot of them that look a bit like this one, where there's a lot of additional work to be done once we've actually developed the functionality in the app?
This is unusually complex because of the sheer number of outpatient appointments. So, the scale of outpatient appointments is such a core activity for how the NHS works that the size of this is unusual, I think. But documents and letters in general will be similar, which is why we're looking really carefully at how do we design out some of the obstacles and some of the challenges. Other features that are there to be delivered, some of those will have dependencies of different types. So the app is very much like a platform, and elements of the app draw on services from NHS England, or they draw from other systems, and so we often have dependencies in that regard. As lots of board members will know that for quite some time we've been looking at the Welsh language screens in the NHS login component, for example. NHS login is a component provided by NHS England, so we've agreed a work plan and a cost for that work with NHS England. But NHS England have all, very recently been absorbed into DHSC, so there's quite a turbulence going on in NHS England, which makes it difficult for them to confirm a definite timetable to conduct that work, and so we have that kind of dependency on some of those features. And in the prescription area as well, we use some NHS England services for prescription and for pharmacy search, and again we've got some dependencies of that sort. They're not as complicated in terms of volume and variation as outpatients, but there's still an external dependency that we have to manage the best we can.
Okay. Fine. Marion.
Thank you. Thank you, Chair. Can I just go back to one of the points that arose from the IQPD feedback, in that delivering technically the app is not deemed to be sufficient. We need to be tracking usage and adoption of various features as well. What's the potential for DHCW to be able to influence the take-up and usage? Because that seems to me is going to be key going forward. We've been asked to track the usage, but what's the next step then in terms of following through, trying to influence and to increase adoption when that may be deemed to be insufficient?
Yeah, I think so. We track usage. We run metrics on the app. We can say that we've got as of today probably 500,000 registered users of the app. It was 495,000 2 weeks ago. So, and we can track how many repeat prescriptions are being ordered, how many appointments are being viewed, and we track weekly rates and whether the weekly rate is increasing and so on. So that's usage as usually conceived. I think the concern, it comes back to my previous point, the concern for ministers is that within the program we can technically deliver a feature, but until there's content flowing through that feature, it's not perceived as available by users. And GP appointments would be a really good example. So GP appointments, GP repeat prescriptions, and the GP summary care record are features that are available technically across the whole of Wales, but they rely on each individual GP to enable those in their system, either for all of their patients or for individual patients. There's a high degree of flexibility for GPs to do that. There's not much that DHCW can do directly. Of course, we can go out and persuade, and we do, working closely with Sam's team through our regular engagement with GPs. But the GP profession works in quite an organised way, and those discussions are part of the annual contract negotiations led by the Welsh Government itself. So, and I know they're within the scope of that discussion. DHW is not a party to those discussions, and so we can't directly influence that. What we can do, though, is provide information to Welsh Government on where we are, the extent of variation, which practices have enabled things, working with health boards to do that, because again, health boards manage the local relationship with their GP practices too. So we do what we can there on use. That is, and so there's a difference between the content that is available. So we're still working. Is it adoption? Is it onboarding? Is it enabling? Is it content? Is it use? The more that is in the app, the more useful it is to people, the more it engages them, the more they will return to use more, and the more they will then discover other features and content that is available in the app. And I think we're discovering that it's a platform as much as it is a product, and so we've got lots of reliance on lots of other people to feed data into and through the app.
So I guess presumably then we would be escalating if there is concern about a lack of adoption of certain features which could transform the NHS in Wales and people's usage and access to it. We have some sort of escalation process to highlight the lack of potential adoption?
Yes, although I'd say that in practice we don't need to escalate, because government is as focused on this as we are. So if it feels a little bit as if it's escalated to us by the Welsh Government rather than us escalating to Welsh Government, but technically you're absolutely right. Yes, that's what we would do.
Okay.
Yes.
Rowan, take one last point on this, and we probably need to move on then.
Thank you, David. Ivan, just touching on policy there. Do we have enough support on policy around, our, because at the moment we're influencing. The Welsh Government wants us to get this done. Have you got any comments on policy gaps in terms of particularly the data governance, the ability to be a processor versus a controller? And how that perhaps impacts on some of these things. So I think there's a lot of willingness across the system to achieve these, but sometimes, there is unintended consequence of us having to go project by project and agree governance across the system.
Yeah. I don't think there's any misalignment of policy and governance. I think that the policy position is clearly expressed, in terms of expectations from government, and they completely align with what our assumptions are. We, like government, want to get as many features live and as much content through all of those features as we possibly can, because that's what will drive use of the app. And what the strategic objective is for DHW in its own strategy is a million users regularly using the app. They've got to regularly use it, and to do that we have to have the content. I think with the benefit of hindsight, it may be that that what we were describing in our discussions with government and with stakeholders about, we'll deliver an alpha by a particular time and we'll deliver the live feature by a particular time, and then we're going to have to onboard, that distinction maybe has been lost in some of those conversations, and people have assumed that the delivery of the alpha is the delivery of an universal service, all Wales, all users. So we're trying to use this concept of we deliver alpha, then we deliver live, then we work towards all Wales, all users. That's the phrase we're using at the minute, to help to understand for everybody what we're talking about at different stages. And I think that's the only misalignment that we've had, really. We're all heading in the same direction, and we all want to get to the same place quickly.
Fine. Okay, thanks. I think we're going to move on to Connecting Care now. Thanks.
Yeah, thanks, David. And just to say, as SRO, I'm glad there was a conversation about that. I know it's extended, but this is probably the one that's my biggest concern in terms of milestones, for the reason that Marion picked up on in terms of her question. I think the technical feature delivery isn't sufficient, and how do we work with the system, with the governance we've got, with partners to get the visibility on usage, uptake, adoption increased. So that's exactly what's being worked on now. In terms of 3.2, the milestone around the Connecting Care specification and commercial strategy. So we had the funding approval for 25-26 last week, I think it was. Clearly, the business case and the procurement approach is unlikely to be in place within the next month. But Sam, do you want to comment on this?
Yeah, thanks, Chris. Yeah, Sam Hall, Director for Primary Community and Mental Health Digital Services. So yes, you're right, Chris. We do actually have a strategy. We're currently working through that with our partners now. There's a working group that's been put together with the health boards for them to effectively approve the proposition in the strategy that we're putting forward. We hope to be able to take something on that. Our programme board is actually the end of this week, so we'll be taking progress to that Connecting Care programme board. There's also, we've been running a parallel piece of work with the strategic programme for primary care and with support from Welsh Government colleagues around the need to look at a cluster solution as well across Wales. And there's actually some alignment between the community health product and the cluster products that are in the market. Potentially the different attributes could be supported by potentially one product. And if that was the case, then obviously we would want to look at the economy of scale and the efficiencies of doing that. So we're actually running that alongside this piece of work now, looking at the requirements for both to see if there is a quicker, more sensible and more cost-effective win here as well. And I think it's prudent that we do that before we go out to market in case there is more utility in the system we want to buy. So I think that's important, but we are working through that now, and we'll look at what the revised date might be. I don't expect it to be particularly much longer, as the strategy is already there and we know how we need to get to market. We just want to make sure we've got the right requirements in there if they need to take into account clusters as well. So that's the first thing. I think the second thing is a point of concern to note, and that is we're really grateful for the funding that's come through for Connecting Care this year, that specifically actually around some of the funding for devices, which is really important. This system, any system we buy which is kind of new and modern will require devices for our people out in the communities to use. They don't all have those. It's all very good, all well and good having a system but if people can't access it and use it to its full potential, then it's not really that useful. And so being able to support that through devices, that we really welcome that, and it's definitely welcomed by our health board partners, is the first thing. The second thing is a note of caution, and that is that this funding is for 1 year, and so going out for procurement and committing to a path of delivery for Connecting Care, that's going to be difficult for our health board partners, because we're asking them to commit to something that they can't guarantee funding for year on year. So that has already come through in some of our conversations. We'll be working through that, and obviously we'll raise that through our programme board. But as you can imagine and will appreciate, signing up for something which is a multi-year programme that only has funding for the next handful of months has raised some concerns. Thanks.
Sam, just a quick one from me. At what point would that occur in terms of we're in a position where we want to let a contract, but we are unclear on the funding beyond this year? Is that towards the end of this financial year or sooner?
Well, it'll be towards the end of this financial year. So
okay.
As long as we've got we get the approval from the partners that they are content with the strategy around procurement, then obviously we could go to procurement.
Yeah.
But we have no funding to go further than that. So
yeah.
We do need to square that circle before we commit.
Okay, fine. Rowan?
Very quickly, David, can we just put that into the minutes that we need to flag with the board where the risk lies? If we
Good point, Rowan. Thank you.
Yeah, very good point, Rowan. Thank you.
Chris, back to you.
Yeah, and just to note, we're obviously working closely with the Welsh Government Digital Policy team on this. I think the milestone and everything that Sam's described, I think, does feed into how we deliver that most effectively. So the next one, 4.2. So this is NDR related. It's the data migration plan and timetable agreed with stakeholders through the NDR programme board and/or directed by Welsh Government. So this is we've scored as amber. Ivan, do you want to briefly just update on why we're scoring at amber?
Yeah, briefly. So the NDR, I think everyone knows, is a we call it a federated program. So it's a collaborative program, and the health boards and Social Care Wales that are partners are known as federated partners. So they're collective decisions there. Phase 4 of the NDR program, it's a 10-year program with 5 phases. Phase 4 is about the data migration and then the ongoing flow of the historic data into the record to create a whole digital record for Wales by the end of 2026-27. A lot of the last few months has been in conversations around the joint controller agreement, which we discussed just earlier, which Chris had on a previous slide. So probably all of the June and July program boards were very focused on the JCA. We have now found a way through that, but that took the time that we would otherwise have been talking about the practicalities of planning for data migration. Instead, we're talking about the principle of joint data control and whether we were allowed to migrate data in the way that we were planning. So we can now move on to that. It's a reasonable confidence because we may not be able to catch up within the timetable that we'd originally allowed. So there may be some slippage on this. We've got another program board coming up later on this month in September. So we'll see where we are at that point. And then finally on that, we have had plans from health boards. So a large part, about a third of the NDR funding is distributed onwards to health boards. We agreed wording with the Welsh Government in a funding disbursement letter that emphasised the need to align health board plans locally using that funding with the NDR programme objectives, which are very clearly the migration and flow. And that gets close to mandating, but it's not quite an explicit mandate, thou shalt migrate and flow the data. We had those in at the end of August, just over a week ago. And so we're working through those at the moment to see what they look like and whether they collectively amount to something that could be described as a plan, a confirmed and agreed plan for data migration. So we've got progress, but we've got I've not got a full confidence that we'll be there at the end of this month yet.
Even is that a one-off flow of the data that we have, or is it that and a continuous update of the updated data as it happens?
Well, so migration would be the backload or the transfer, and then flow is the ongoing stack. Although I want to emphasize this in scope for this is only the record. So things like the Welsh Care Records Service, it's an immutable storage in that it's conceptually you write each document to the top of the stack. You don't then go back and edit that stuff. Phase 5 is about the whole digital pathway. And the whole digital pathway is live editable. You might be changing things within a live pathway. So we're only focused on the digital record, not on digital pathways in this phase.
Thanks for the clarification. Rowan.
And Ivan, can you talk about your thoughts and the wider federated partners' thoughts on that prioritisation? So, have there been any discussions about getting sort of certain functionality or certain areas of the record updated across Wales, so you've got the additionality of being able to analyse sort of performance variance across Wales, or is it more of a driving towards what makes sense and the priorities of the individual federated partners, and therefore we might be patchier for longer? I don't know. Can you just give me some colour on that?
So I haven't got a view of where health boards prioritization and sequencing would be about the data that is flowing or migrated and then flowed. We're mainly looking at the direct care data, the CDR. The reason we're mainly looking at the CDR data is because data that comes into the CDR then automatically flows into the analytics platform, and it's in the analytics platform that performance reporting and analysis is done. There's a separate project alongside this one which has been going for some time, which is about the migration of the analytical data flows that we have. So our current architecture, we've got a data warehouse which takes data flows in for reporting purposes. Those are manually extracted from different systems across health boards, and then they're loaded up usually on a monthly basis, and then they become the data set for analytics performance through NHS Performance and Improvement. That work is parallel and that work is ongoing, which brings information directly into the NDAP without it going through CDR. Ultimately, we'll end up where we won't really need to do that, because if everything is in the CDR direct care record, it will also automatically be into the NDAP. And what you'll need to bring in then is the non-direct care stuff. So that would be administrative data or sort of staffing data, which is not usually in the direct care record. So there are two pieces of work that are running alongside each other on that.
Shall I move on, David?
Yes, please.
Yep. And I'm going to try and get through these quite quickly, because actually, so 5.4, this was about RISP go live in a health board and a trust by the end of September, which has been delivered. So Public Health Wales, Powys, and as of yesterday, BCU. So that's good. Not to detract from the fact the programme, there's still a lot of pressure and focus on delivery from here onwards, but that milestone's been achieved. 6.1, the migration roadmap. So there's 32 practices have been migrated to date, and on track for migrating the 40 practices by the end of September. This milestone has proxy measures every quarter just to check if we're on track. The current status from Sam and her team is that we're on track, so not going to dwell on that one. 7.2, the EPMA stakeholder engagement plan. Similarly, there's a draft plan in place. It's going through the approvals process at the moment, so that's really positive. 7.4, so EPS, the rollout to 105 GP practices live by the end of September. So this milestone has just been achieved, so it's slightly ahead of schedule. So the 105 practices, 28% of GPs in Wales, and there's some information and statistics there in terms of how it's being used by the community pharmacy community as well, and the number of prescriptions that have been through EPS. So again, that's positive. That milestone's been delivered. Intensive care. So by the end of September, this was to have essentially the letter from the Director General to NHS bodies, including Digital Health and Care Wales, setting out a programme of activity. There's been milestones over the last few months around clinical workshops and programme reset, and we're on track to have something go to the programme board at the end of September. And I know this has been one with a lot of focus. So Michelle, do you want to comment briefly on this one? I know it is green, but
yeah, so really good progress. I'm really pleased. We've got a really high level of engagement. I've talked to colleagues in the committee about this before, particularly clinical engagement. We've also now stood up a technical group. So we've changed all the governance. So really good engagement from the health boards. There's a lot to do in this space, and they're putting the proposal together now as we speak. So as I said, as Chris said in the update, the 23rd of September, the board will meet. What I'm looking for is agreement from the board then to the recommendation, and that will then go straight to Welsh Government. I think Welsh Government advised they're proposing to meet on the 25th to have an initial look at that proposal. So happy to share that with colleagues as we get to that point.
Thank you, Michelle. So the next one, which is marked as amber, the update I got was green, but I'm conscious Ridian's the exec lead for this. He's not here today, so I've put it as amber. So this is the development and delivery of a data development roadmap for cancer services to address the data shortcomings that hinder the system management and oversight. It links to the performance and productivity Ministerial Advisory Group recommendation. DHCW are working closely with the Performance and Improvement Unit to develop the roadmap with the target date of the end of September. So the feedback was green. I've put it as amber because I don't feel as close to it, if I'm honest, and without Ridian here, couldn't answer the detailed questions. So in terms of the next one, I'm going to just quickly get through the next few, David, if that's okay, because...
Yep.
Oh, sorry.
Paul, just allow Ruth to come in.
Could you perhaps come back to us on this one then, Chris? If there's uncertainty around this, I don't really want to let a potential amber slip past without proper scrutiny. So I just wonder if in future, if the exec lead is not here, then somebody should be here to be able to talk about it. But for this particular one, if you could take a look and come back to us, I don't want to just go, oh, okay.
Yeah, that's
Thank
fine. Yeah, no problem, Ruth. Ridian's reviewing this on Friday this week, so I'll send an update round following that meeting, which hopefully will be confirmation. But as you say, let's make sure we do that. I'll take an action on that. 10.1. So this is a summary report around major program governance, implementation roadmap through our programs delivery committee. So the report is being drafted and Michelle's on the screen who's doing all the work around this. So confident that this will be delivered. There is one thing, because this action, and then if I just jump, just because they link together to the next view, that where the programs delivery committee kind of engagement with the committee, we might just have to think about how we get review, whether it's electronically or whether we have a development session towards the end of this month, because milestones 10.3 and 10.4 were the two areas we were hoping to try and get Michelle and Ivan just to talk through the work to date. We have done a little bit of the work in terms of typology and commercial frameworks. We did it at the PDC development session in May, but there is an update, so hopefully we'll have time just to cover that today. So we'll come back to those two if that's okay. And then 11.4, the stakeholder review. So this is part of our de-escalation criteria addressing the stakeholder review actions. So the position was to have 40% of the actions complete for DHCW by the end of September. We are currently at 53%, so just ahead of that point at this point in time, and we'll continue to track that through to the 100% position. And then the last one is an update on the system-wide action. So you'll recall the stakeholder review had actions for DHCW. It also had a number of actions which were for the system, as they classed it, so the wider NHS Wales system, and we are 45% of system-wide actions complete there. David, just to say, on the milestone delivery plan, that's the current status in terms of delivery. Delivering the plan, I think, demonstrates that we're delivering, gives us credibility, and hopefully moves us towards a place where de-escalation can be considered. There's a number of milestones, and the two on the screen, I think, are key to us remaining out of escalation in the future. So clarity across the system around how major programs are delivered, working at a system level, which is why we were keen to try and just give Ivan and Michelle in particular the opportunity to talk through the work that we've done on this to date. We're then going through it with Welsh Government in terms of engagement and feedback from government colleagues on this work, because I think these are critical for us, not so much on delivery, but on actually having something that means in the future the system works more effectively. So if you're happy, David, I'll stop. That's the 16 milestones for September, and hand to, I think, Michelle to run through where we've got to on those two milestones and the work.
Yeah, I'm happy with that, Chris. This is I think, a significant piece of work that will help us going forward in terms of avoiding escalation in the future. So let's do a brief update on where we've got to now, and then let's have something at one of our development sessions post the Welsh Government meeting to go into this in a little bit more detail if you can. Okay.
Yep. Shall I come in?
Yes, please, Michelle.
Thank you, Chair. Michelle Sell, I'm the Director of Programmes and Engagement for DHCW. There's only 4 slides. As Chris has mentioned, this is something that we will have discussed before in various different guises. And what we're trying to do is pull this together into a bit of a summary, really, that hopefully makes sense, but you will be the test of that. And moving forward, it's working on, now we've pulled this together, how do we want to take it forward, really, and how does this help us in terms? So I'll run through, as I say, 4 slides. I'll do it fairly quickly. But obviously we can revisit this. So I should, she says, put this into slideshow mode. Apologies. Okay, so this is about how we kind of describe the different types of programs and the different approaches that we take in terms of contracts. And this is reflected on where we've come from as an organisation and the different models that we've actually been operating. And sometimes that happens intentionally, and sometimes it's kind of evolved as we move forward. So what we're calling our program typology, we have identified there are basically three main types of program structure. And you'll notice one of those has got a couple of subtypes.
Michelle,
Michelle, you're not sharing your presentation slide
Yeah,
screen.
I'm just getting the title page.
Ah, okay, that's not moved on. Okay,
Might be wrong screen, Michelle.
Yeah.
I think it's on the right screen, but let me just try again. Let's try.
I can share for you if you want to keep talking. Oh no, you're in presenter view there.
Right. So that is sharing the wrong thing. It was the.
I can see that, Michelle. So if you want to.
Do you happy? Will I just run through with that for now, rather than fiddle with the technology?
Sorry, it's a bit small, but we can see it. Thanks.
So three main types of programs. So we've got what we call DHCW delivery programs, and there's a few examples there. So that's generally where the implementation is led by this organisation, working directly with suppliers, with implementation decisions really driven, I guess, from within this organisation. So we've put the app is an example of that, which has principally been led by us through Digital Services Patients and the Public, Welsh Nursing Care Record, EPS, so electronic prescribing, are some examples that broadly fit within this category. I think category 2 is mainly where we live, because most of the programs that we deliver are done in collaboration with our Health Board and Trust partners. So we've got two subsets here. So we've called this national partnership programs. We've got those that sit around a single contract. So LIMS is probably the most obvious example. We would have discussed that quite a lot. We've also got NDR in terms of the platform, the contracts that underpin the platform. So DHCW in this case is the contracting authority, holds a single contract on behalf of NHS Wales. Generally, there would have been one consolidated business case, programme funding flows from Welsh Government through DHCW, and then some of that funding onto local delivery partners. We are accountable for the delivery of the programme. Implementation decisions are made collaboratively. And in terms of the governance, there will be a national programme board. There will be collective decision making through that board with an independent programme oversight chair and local implementation boards. So that's the kind of structure. That's where quite a lot of our activity lives. The distinction, I think, for the 2B, if you like, is what we've called a joint contract situation. So this is where RISP is. So Chris mentioned RISP earlier in the update, the radiology system, where in effect an overarching contract is held by DHCW, but each local organisation owns their own contract. So commercially, this is a different delivery model, which leads to an actual difference in the delivery model. And I think the main difference here is that decisions are determined locally under individual contracts. So that is a distinctive difference. Again, we've got national governance in place that sits around this, but that decision making and that contractual accountability does have quite a significant difference in delivery. So that's definitely one for us to think about. And then we've got what we've called national support programs. So again, we have a role as an organisation in supporting our Health Board and Trust colleagues to deliver, but it's much more of an arm's length role. So generally the contracts are distributed. So EPMA, so we know with our EPMA solutions, it's a multi-supplier framework. Health boards have selected different suppliers to deliver their EPMA solutions. So those are absolutely managed decisions are made locally. And our role is to try to provide some coordination across the top of that, and often to provide integration. So the majority of products don't actually stand alone. They still need to work with the national architecture. So we do have a role there. I think legacy packs is another one I would put in there. So again, legacy packs has transitioned to RISP. So we've actually moved to a more coordinated, deliberately, to a slightly more coordinated program. So those are our program types. I think we will certainly have discussed those previously. So if I move us to our contract types, so this is again the contract typology. You can see if you start at the top there, so I mentioned it earlier, we've got some situations where we've got a single or Wales contract. So again, LIMS is probably the clearest example of that, where we act as the contracting authority on behalf of NHS Wales. So the service delivery is actually enjoyed by the health boards and trusts, not by us, but we actually manage that contract on their behalf. And that we are suggesting is, you can see a bit of the forward direction there, the most straightforward way to deliver a single managed solution. And that is, in fact, what we're doing in that situation. You've got a master services agreement, which is the kind of model I just spoke about for RISP, where we have a high level contract and then we have individual contracts held by each organisation. And you can then work through the list really at the bottom. Obviously, we don't procure everything that we deploy under our programs. We've got some bespoke development through third parties. That's where the app comes in, or some things are obviously developed entirely in-house. So these are the kind of different contract types that we may enter into. And there's a little bit more in the slide about some of the advantages and disadvantages of those different types of delivery in the main areas. So the majority of our national programmes would be operating under one of these 4 models. And the final point, just wanted to bring in as well, so obviously we'll be reflecting this into our thinking, as well as the national target architecture work that is currently underway across Wales. So this is the Once for Wales typology. This, I can't take credit for this. This actually came from the Minister, from Welsh Government, in terms of how they wanted to see digital solutions deployed across Wales. So we've got the concept of 3 tiers. From the higher tier, which was the common solution, again, probably LIMS is a good fit, to the base tier, where we're saying that absolutely it's essential, however we're taking these solutions forward, that we're able to share data. So those are the kind of main categories that we've been working on. And as Chris said, I think the next thing is we have got a session with Welsh Government this afternoon to talk about those and see whether that fits with their sense of where things are. And then it's to think, I think, about how we take that forward.
Okay, thank you for that, Michelle. Great piece of work. I'll look forward to the follow-up session we'll have post your Welsh Government meeting on that. Okay, Chris, is there anything else you wanted to cover in this section?
No, I think it was just to say, with that work, it's, for me, it's something that comes out of it that's practical and usable, so that when programs are instigated, there's a clear, whether it's a decision tree or mechanism to agree how programs are established, that's signed up at a system-wide level, and it's agreed whether it's done nationally, regionally, or locally. And I think perhaps that would take some of the debates that take place then after the event out of it. So yeah, just very grateful to Michelle and all the teams that have worked on this, because I think it's a really critical piece of work for us from an escalation perspective. No, David, in terms of the current position, I just wanted committee members to be aware of the status of the milestones, where we're at now in terms of the September milestones. I know we've got 2 or 3 weeks to go, but where we're at, and just have that engagement on the typology and commercial position.
Okay, great. Thanks, Chris. Has anybody got any points they want to raise on this before we come to the closing section of the meeting? Marion.
Thank you, Chair, and thank you, Michelle, for the clarity of that update. Very, very helpful indeed, and it'll be good to see the outcome of your session this afternoon as well at our next session. It is 6 months Thursday since we were escalated to level 3. And I'd just like to say, I think what we've heard today in terms of progress has been impressive. And I'd like to congratulate the teams on the hard work that's been undertaken to get us into this position. Collaboration was one of the themes that was highlighted in terms of modus operandi, and it appears to me certainly that there is a very collaborative approach here between DHCW, Welsh Government and the Health Board as well, which is very pleasing. The third deselection criteria, and you mentioned that, Chris, in your presentation, was the actions arising from the stakeholder survey. And I just like to say how pleasing it was to hear that 6 months into escalation that we have well exceeded our target milestone. So I think it's good progress. So well done, everybody concerned.
Thank you, Marion. I would concur with those sentiments. Okay, anybody else want to say anything? Otherwise, I'm going to draw this meeting to a close. Okay, fine. So AOB, I've not been advised of anything in advance, so I'll just pause in case anybody wants to raise something. Marion, did you want to come back in, or? No, okay, fine. Right, the date of the next meeting then, this will be our normal quarterly meeting with a session to look at the improvement plan. That's on the 6th of November. I'll now draw this meeting to a close and thank everybody for participating, and for any that wish to view this as a online recording, which will be made available after the meeting. Okay, thanks everyone. Diolch yn fawr.